Anthony DeMaria returns, this time with Dr. Dalane Kitzman, Professor of Cardiology and Geriatrics at Wake Forest University School of Medicine in Winston-Salem, North Carolina, to discuss the effects of endurance training on the determinants of peak exercise oxygen consumption in elderly patients with stable, compensated heart failure and preserved ejection fraction.
So welcome, Dalane. Why don't you, if you will, give us the rationale for why you undertook this study?
Thank you, Dr. DeMaria. Well, as you know, heart failure with preserved ejection fraction is actually the most common form of heart failure in older persons, and as you stated, its pathophysiology is not well understood. But we do know that exercise intolerance, exertional fatigue, and dyspnea are the primary symptom that these patients have, even when they're well compensated and non-edematous. And it appears to be a significant correlate of their severely reduced quality of life. So our work has been seeking to understand the mechanisms of exercise intolerance and apply some types of treatments.
This goes to the age-old question of why people develop exertional incapacity in the setting of heart failure. Is it primarily central related to the heart itself, or is it related to peripheral mechanisms, or both? And that's been looked at extensively in heart failure with reduced ejection fraction. And your study, I believe, is the first one that's looked at this question in heart failure with preserved EF.
Thank you. We believe so. We began by reminding ourselves of the Fick equation, which is that total body oxygen consumption during exercise equals cardiac output, the central component, multiplied by arteriovenous oxygen difference. And using the Fick technique, if we are able to measure two of those three variables non-invasively, then we're able to calculate the other. And we did that by developing a mechanism where we were able to measure LV volumes during peak exercise with echocardiography.
And so measuring the volumes enabled you to assess cardiac output. What was the exercise protocol?
It was a standard training protocol, was a standard aerobic exercise 3 times a week for 45 minutes, beginning with simple stretching exercises and then building up incrementally with individualized goals using a combination of walking, treadmill, and bicycle.
So you studied a series, as I recall, of more than 50 patients with HFPEF, heart failure with preserved ejection fraction, and about 25 controls, and made careful measurements of cardiac output and the AVO2 difference reserve both before and after this protocol of exercise training. What were your findings?
We found that, first of all, that exercise training was safe, even in these very elderly, older women, really quite frail with severely reduced exercise capacity. We had some women who had never pedaled a bicycle, for instance, and we had to train them even to do that before we could even do the exercise testing. So we were gratified that we had excellent safety and feasibility. But even further, that exercise capacity as measured by a gold standard, peak VO2, improved by about 24%. And also this was associated with improved quality of life.
That was in both groups?
That was in the exercise training group. There was also a group that received attention control who continued their usual care but were not enrolled in the exercise program. They also received by every other week follow-up telephone calls to assess their quality of life and add some type of attention control. Controls did not improve.
What accounted for the improvement? Could you determine whether it was cardiac or was it related to peripheral mechanisms?
We began last year by examining our data before patients were randomized into the exercise training program and using standard regression analyses and a normal, healthy age-matched control group in order to ask at baseline which components, cardiac output and arteriovenous oxygen difference, accounted for their severe deficits in peak oxygen consumption. and we found that both cardiac output and arteriovenous oxygen difference were equally abnormal and accounted each for about 50% of the deficit of peak VO2. But that's a different question about which one of those can we change the most and influence by exercise training.
And what did you find when you exercise trained the patients?
Cardiac output had minimal change. There was an improvement in exercise peak heart rate, and we had previously reported that these patients have significant chronotropic incompetence, and that improved, but it was balanced by a mildly reduced peak stroke volume, which was opposite of our a priori hypothesis. We had thought that Frank-Starling mechanism would improve with exercise training, but it did not. So the overall unbalanced cardiac output was not different in the exercise-treated patients after the exercise training protocol. However, the arteriovenous oxygen difference was significantly improved by 14% and was the primary determinant of the improvement in exercise capacity in the multiple regression analyses.
Well, that's fascinating. I know there was an accompanying editorial to your paper that will appear from Matt Maurer at Columbia, where he focused a lot of attention on the ability to improve overall exertional capacity in these HFPEF patients by virtue of perhaps changing peripheral circulatory and even muscle dynamics. Was that one of the conclusions you were drawn to as well?
Because arteriovenous oxygen difference improved, it suggests that either a terminal delivery of oxygen to the muscles via small arterial or capillary density, or the skeletal muscle function itself improved. And so while we cardiologists might be somewhat disappointed that we were not able to remodel and improve function of the heart by this treatment, we should be enthusiastic that we were able to improve their overall symptoms and exercise capacity, and we may need to begin looking at the periphery as a potential target for treatment.
Boy, that's one of the things that impressed the editors as we read your manuscript, the fact that in this condition, which has proved so resistant to therapy, that the potential for exercise training to induce real benefits in, at least in symptoms, and who knows, perhaps in overall survival, was very exciting.
We were also. In fact, these are fairly robust changes. The improvement in exercise capacity was far greater than the 1 milliliter per kilogram per minute that is usually chosen as clinically meaningful. And improvements in quality of life were quite substantial. And we've actually completed and published studies using medications for the same target and have not been successful, and others have had similar results. So to find any treatment, including one that's non-invasive and is widely available that improves their symptoms, to us was very favorable.
Now, have you incorporated this into the actual management of your patients with heart failure preserved ejection fraction? Are you systematically submitting them to an exercise training protocol?
A good question. I respond by saying that there have now been 4 studies that reported that exercise training of one form or the other improves exercise capacity in these patients and usually their quality of life. One of those was in your journal last year by Edelman and colleagues, and it was a multi-center trial. So even though they called their study a pilot study, when you combine 4 studies, you get nearly 200 patients. And I personally believe that the question of feasibility, safety, are well resolved, and probably efficacy as well if the outcome is exercise capacity and symptoms. So I personally believe that this is ready for application to patients. Now, Medicare has variable payment policies between the states, and some of them do not allow reimbursement for cardiac rehabilitation, even for heart failure with reduced ejection fraction, let alone for this syndrome. So that's one of the new steps in research and in public policy, which is to now disseminate this treatment and convince third-party payers that even though we don't have data that it improves mortality and clinical endpoints, that this is an important endpoint worthy of reimbursement?
Well, I can tell you personally, I pulled my hair out at the lack of therapeutic alternatives in these patients with so-called diastolic heart failure, and the potential of exercise training to produce real benefits in symptoms and functionality is a great advance. I certainly will try to implement this in my own practice however I can, and we look forward to further work from you and your colleagues in providing more insights into the pathophysiology of this syndrome and potential therapeutic alternatives. Thanks for sharing this with us.
Thank you, Dr. DeMaria.